Hello, everyone, and welcome to our latest webinar for the PDC Mums and Bumps on birth and postpartum with type 1 diabetes. My name is Caitlin Parker. I'm an accredited practicing dietitian, a credentialed diabetes educator, and I live with type 1 diabetes. I've gone through two successful pregnancies with type 1, so this presentation will be made from um, literature as well as input from myself and our CDE midwife, Kate, as well as a little bit of personal experience as well. To start off with our disclaimer, this information is general in nature and it's important to consult with your healthcare team for more specific advice on your individual situation. It's really important. This information is aimed to inform you, not scare you, so that you're aware of what can happen and empower you to self-advocate and feel confident in your birthing experience. We'll go through a couple of different parts today. So part one is all about preparing for birth. So talking about our birth plan, we want to think of this as a wish list, including our preferences for things like our birthing environment, pain relief options or preferences, birth positions, labor aids. So whether it's things like massage, deep breathing, TENS, shower, Fitball, cold or hot packs, as well as anything else, as well as any specific preferences for the birth process. So this is something that all women during pregnancy think about. But when we add type 1 diabetes into the mix, we also want to add things about our diabetes management into our birth plan too. So things that we might consider with diabetes during birth is who will manage our diabetes during labour and what will their responsibilities be. So it may be a shared job between you and your partner or whoever else is there to support you, or it could be that you want them to take over a majority of the management, or you would like to do a majority of the management unless you can't. You might also have a backup plan in the event of tech failure. So whether it's your pump stops working, your CGM stops working, or anything else. You want to know what your target blood sugar levels will be during this period, as well as our diabetes tech and where we will place it. And we'll talk a little bit more about CGM and pump sites and the C-section as well a bit later on. You want to know what your preferred treatment for high and low blood sugar levels is, and make sure that you've got lots of snacks for low blood sugars on hand as well. You might also want to set someone up to follow your CGM as well. Um, so this is that they don't have to keep asking you what your blood sugar level is. They may have it on their phone as well and they can just check it. One of the questions that we have a lot is asking about induction. So most people living with type 1 diabetes will deliver their baby between about 37 to 38 weeks. And this is because there are studies which suggest that decreases the chance of stillbirth in women with type 1 diabetes. You and your team will carefully weigh up the risks and benefits of induction for you and your baby when advising you on the birth timing or when would be a good time for you to deliver your baby. Some of the reasons that you may be induced earlier, we'll talk about now. So the first one is preeclampsia. So this is a condition during pregnancy that's characterized by high blood pressure as well as protein in the urine, and it's very high risk for both the mother and the baby. The only cure to this is to deliver the placenta, so to give birth. And so often having or being induced or having a C-section earlier may be recommended. The next one is macrosomia. So this is a large birth weight. Depending on what you read, it's a birth weight of over 4 kilos or over 4.5 kilos, and it poses a risk to both the mother and baby. Risks to the mum include the need for an emergency C-section after an attempted vaginal delivery, hemorrhage, and also perineal tears. The risks to the baby include shoulder dystocia and the associated injuries, which we'll talk a little bit more about later. Low APGAR scores. So this is the scoring system that they use to determine the health and well-being of your baby at birth. Higher scores are better. Hypoglycemia or low blood sugar, and also higher rates of NICU admission. You may also be induced earlier due to changes in fetal movement. So it's important to contact your hospital to get checked if you notice that your baby isn't moving in their usual patterns. So just like us, they may move less if they're feeling unwell, and it's always best to get checked if you have any concerns. The next one we'll talk about is placental deterioration. So the placenta is the interface between you and your baby. It's how your baby gets all of the nutrients that they need while they're in your belly. If it's not functioning properly, your baby won't be able to access enough energy and oxygen. The placenta produces hormones that increase our insulin resistance. So this is the main reason why our insulin requirements increase as we go through pregnancy. If the placenta starts to break down, it won't produce as many of these hormones. And that means that our insulin sensitivity increases again. So you might find that your insulin levels, or you don't need as much insulin anymore, or you're having a lot more low blood sugar level. If you notice either of these things, make sure you get checked by the team at your hospital so that they can make sure that everything is functioning okay. Intrauterine growth restriction can also be a sign that the placenta isn't working properly. When a C-section might be required, so there are a number of situations where a C-section is the preferred method of birth. So this could be due to fetal complications. So their heart rate might be showing signs of distress. If there are any maternal complications, so maybe something like preeclampsia, macrosomia, because of that higher risk of shoulder dystocia, or breech position. So this is when they're in the wrong position and they're unable to be moved by a doctor or a midwife. We've talked a lot about induction, and now we'll talk about the methods of induction. So the first one is prostaglandin. This is a hormone or hormones that are placed in the vagina to ripen the cervix. It could be either a gel or a pessary. And once the cervix has ripened, the next steps of induction can then proceed. Another method they might use is a balloon catheter. So this is where a thin tube is placed inside your cervix and then it's inflated with saline to place pressure on your cervix and encourage it to ripen. Artificially rupturing the membranes. So once a cervix is ripe, the doctor or midwife will use a small hook-like instrument to break your waters. Syntocinon or syntocin is a synthetic form of oxytocin given via IV drip to stimulate contractions. If this method is used for you, you must also be monitored by CTG once this is started, and this is a picture of what that might look like. Again, we've got an extra layer of complexity on our pregnancies with type 1 diabetes. And one of the things we might consider the impact on our blood sugars is the various types of pain management. So our non-medical pain management strategies, the ones that have no impact on blood sugar levels are sterile water injections, the TENS machine, or relaxation techniques. So things like deep breathing or gentle massage. The ones that might impact our blood sugar level are heat and water, and also active birthing, so moving around and changing positions. Heat can increase our insulin sensitivity, so we may find that it makes our blood sugar levels drop or decrease. We also want to think about where we put our pump if it's not waterproof and you're thinking about using water in your birth. We want to be mindful of the insulin that we have on board and low blood sugar if we're moving around a lot. The more active insulin or bolus insulin that you have on board, the more likely you are to have a low blood sugar with exercise. The medical pain management options. So most pain relief medications don't affect blood sugar levels, but there are still some things that we can take into consideration. So epidurals can be used, and these can easily be topped up if you need an emergency C-section. They can be good because they allow time to rest and recover if we have a long labor, which is more likely to happen with induction. But even though you can't feel the pain, your body is still working really hard and using lots of glucose, including all of your stored glucose or glycogen. So we want to make sure that we're prepared for low blood sugar. The Australian Diabetes in Pregnancy Society reports that around 56% of women with type 1 diabetes will experience hypos in labour, which is amazing. Some of the side effects that we can sometimes get with this pain management is nausea and vomiting. So this can be found with the nitrous oxide gas, epidurals, and also morphine or pethidine. So they can cause nausea. We want to be mindful of this, of vomiting and its impact on our blood sugar levels, as well as that nausea and not really feeling like eating anything. As with most situations with diabetes, we want to make you feel like you can advocate for yourself. So women have the right to decline care or advice if they choose, or to withdraw consent at any time. Therefore, if a woman declines care or advice based on the information provided, her choice must be respected. So every hospital has their own policy for diabetes management, and it's important to discuss this with your team at your antenatal appointments. Most of them will allow you to self-manage your diabetes unless you can't. You may also recruit someone to advocate for you on your behalf. So this might be your partner or a student midwife, and they can be your voice in case you are unable to advocate for yourself during birth. You also have the right to ask for a second opinion or to speak to a supervisor if you feel like something isn't right. Moving on to part two, so the main event. This is what we have been preparing for months and months. So if your birth goes down the C-section route, it might be for a couple of different reasons. So your team might suggest it if you've got suspected macrosomia or large for gestational age baby. The baby's in the breech position. You have retinopathy or kidney issues, or there are concerns for the baby's health. If you do have a C-section, you'll likely be the first on the list. If possible, the IV will be placed before fasting, usually 6 hours, in case there's any hypos. And the other thing is that some women get shakes and vomiting from the medications that they use. So make sure that you have a clear hypo plan in place with your team and management strategies for this. One of the best people to talk to about the medications that they use during C-sections is your anaesthetist or their assistant sometimes. So if we've got a planned C-section, the anaesthetist will usually call you a day before or a couple of days before just to talk things through with you. So some of the questions that it can be really helpful to ask them are the fasting guidelines. So at what point you have to stop eating and what point you have to stop drinking. And then if they have, they can recommend some acceptable hypo treatments. So it might be something like glucose tablets is their preferred method. You can also talk to them about the impact of any planned medications on your blood sugar levels. So they're the expert in these medications and they can sometimes provide alternative options to basically help mitigate the risk to blood sugar levels. They may also ask, or you can show them or their assistant your pump and your CGM, how it works, and how they can check your blood sugar level if they need to. And basically just giving them a bit of a rundown about yeah, how it works, what to do and what to expect, what the alarms mean sometimes as well. Speaking instead about vaginal birth, so this one is made up of a couple of different stages. So stage one is where the body prepares. So the latent phase is where the cervix thins and dilates, and you could already be in this phase when you're induced. The active phase is when you have stronger contractions and more cervix dilation. And the transition is where there's full dilation, intense contraction, and the baby's head is descending into the birth canal. Stage two is when the baby's delivered, and stage three is when the placenta is delivered. Thinking about your blood sugar levels during active labor. So, active labor uses a lot of energy, even if you can't feel it because you've had an epidural. You've got whole body glucose utilization, and this increases as your muscles contract. And because of this, we've got an increased risk of hypoglycemia. You might choose to use temporary basals or temporary targets or an ease off mode to help try and reduce the risk of low blood sugar level. The blood sugar levels during labor, the targets are higher than during pregnancy to reduce the risk of hypos while also aiming to prevent neonatal hypoglycemia or low blood sugar in your baby. The target blood sugar during labor is 4 to 7, and it's thought that blood sugars over 10 are associated with neonatal hypoglycemia. Labor can last for days, so make sure you pack extra diabetes supplies, a variety of snacks and hypo treatments to sustain you for this extended period. Another thing to be aware of is ketones in labor. So we've got whole body glucose stores being depleted, which can then stimulate ketogenesis. And this can also be exaggerated because of an insulin depleted state. So you might not be giving yourself much insulin because you're not really eating. High ketone levels can affect the baby's well-being. So if ketones are greater than 0.6, doctors may start an IV glucose and insulin infusion and monitor the baby's heart rate. Diabetes self-management during birth. So in most scenarios, you and your support person will be able to self-manage your diabetes. The exceptions include DKA, or high ketones. This one might be measured with that IV glucose and insulin drip. If you're under general anesthetic, or if you're not able to show that you can manage your blood sugar levels any longer for whatever reason. It's important to discuss your diabetes management for your birth with your obstetric or your diabetes team at your antenatal appointments. Each hospital has different policies, so you'll need to ensure that you and your provider are both on the same page. If you are on multiple daily injections, some of the things that you might consider during birth is your long-acting insulin. So your team might want you to reduce your long-acting insulin dose the night before induction or C-section to account for the work of labor and also the decline in insulin requirements once that placenta is delivered. If we're instead using an insulin pump, we want to make sure that we change the pump site, the battery, and the sensor the day before induction to avoid any issues with a failed site on the day of the birth. We just want to try and minimize the things that can go wrong with diabetes. Keep your sites, so your infusion sites or your CGM sensors away from the possible C-section surgical areas, even if you're being induced, just in case there's an emergency. So you might choose to put them on your bum or further around your hip or back of your arm if possible, or your thigh. You must use a plastic cannula, not steel, for C-sections because the surgeon could use diathermy. And remember to have a plan in place and change to your pre-pregnancy insulin settings um, at the point of time that's thought to be best for you. So we can discuss the timing of this with our diabetes team, as well as whether they recommend you go back to your pre-pregnancy settings or even a little bit less. So we mentioned a couple of times shoulder dystocia. So this is a birth complication where the baby's shoulder becomes stuck because the mother's pubic bone. It's unpredictable, but there are several things that increase our risk. So the mum living with diabetes, macrosomia or a large birth weight, induction of labor, prolonged first or second stage of labor, and a big difference between the head circumference and the abdominal circumference on the ultrasound. If this happens, it's an obstetric emergency, so help will be called in. They'll use birth interventions, so something like episiotomy, forceps, or vacuum, and maneuvers will be used to ensure a safe delivery. Part three, so this one is all about early postpartum. So one of the biggest things that your healthcare team will look out for here in your baby is newborn hypoglycemia or low blood sugar. So the reason that this can happen is the mother has higher blood sugar levels. So even if they're within target for pregnancy, they can be still higher than average or higher than normal. So we've got high blood sugar level in the mother. All of that extra glucose is supplying your baby. And because of that, your baby's pancreas, which works, is stimulated to produce more insulin. Birth happens, and the baby no longer has access to your glucose supplies, but their pancreas is still producing insulin as if they are. So because of that, for the first few hours after birth, they're at an increased risk of low blood sugar. And so the healthcare team will monitor their blood sugar level in order to treat it as needed. It's more likely to happen if your baby is born early or if it's small or large. And most of the time, glucose or low blood sugar is treated with expressed colostrum fed via a syringe, which looks like that. They might use formula. They could use a glucose gel, or they may need special care. So they might get an IV drip if these treatments are not effective. This is one of the best or one of the main reasons for expressing colostrum, and the guidelines for how to do that are down here. So one of the things that you may have heard about is skin to skin after the baby is born. So the benefits for the baby are it calms them and regulates their heart rate. It helps the baby to regulate their temperature and their blood sugar levels. This triggers the feeding instinct and it allows the baby to naturally move to the breast. The benefits of the mother, it releases hormones that stimulate milk production. It helps with bonding, which decreases the risk of postpartum depression. With diabetes, we've got a higher risk of postpartum depression. You may have heard that it might be harder for women with diabetes to breastfeed, but this is a common misconception. It's possible to breastfeed, but there are a couple of different things that you might need to be aware of before you start your journey. The reason why some women living with diabetes have trouble breastfeeding is the increased occurrence of early mother and baby separation due to higher rates of birth complications. So this might be that your baby is taken to help them with their blood sugar level or something like that. Immediate skin to skin time after birth is an important step in establishing milk supply. and we want to make sure that we have this skin to skin as soon as possible. If able, try breastfeeding within the first hour after birth and breast produced milk on supply and demand basis. So keep feeding or keep trying to feed frequently to stimulate this milk production. We often talk about the milk coming in. So research suggests that most women with type 1 diabetes typically have the same timing of their milk coming in as women without diabetes. But uncontrolled, in inverted commas, blood sugar levels can delay the milk coming in. And one study suggests this delay averaged to be about 1 day. If you can't breastfeed straight away, express as much as possible. Hospitals usually have pumps for you to use while you're an inpatient. Breastfeeding is often talked about as being something that's really easy and really natural, but it's actually really hard and takes a lot of work. So there is no shame in asking for help or even just checking in to make sure that you're doing it right. So some of the people that you can ask for help are the Australian Breastfeeding Association. So they have a 24/7 helpline and they also have a messaging service. They also run workshops for pregnant women to kind of let you know a little bit more about the expectations and strategies for how to get breastfeeding established. The Breastfeeding Centre of WA, this one provides lactation consultants and they can offer it in person or over the phone. And you can self-refer if you gave birth at King Eddie's. Then we also have private lactation consultants. So check with your pregnancy team for availability at your hospital or whether you see someone separate to your hospital. Once our baby is born, our insulin settings usually return to our pre-pregnancy settings or less. So as soon as that placenta is out, the hormones that cause the insulin resistance are no longer being released, and our insulin requirements go right back down very quickly. Most people use less insulin than before pregnancy, especially if you're breastfeeding. We also have a change in our target range and expectation. So during pregnancy, the target range is quite strict and quite low, and the goal is to stay within that target as much as we can. Once a baby is born, the goal changes. So the target range goes back to what it was pre-pregnancy. And also the main priority is just making sure that we don't have too many hypos because we've got a baby to look after. We've got a couple of suggested packing lists from a diabetes perspective for a hospital bag. So we want insulin, enough for 5 days. And so if you're on injections, this is long acting and short acting and pen tips. If we're on a pump, this is enough infusion sets, reservoirs, inserters if you use them, alcohol swabs, and pump chargers or batteries. With our glucose monitoring, we want spare sensors, spare transmitters if our system uses them, glucose testing kits, and also ketone strips. And we want a variety of hypo treatments, so both fast-acting ones like juice boxes, lollies, honey, soft drink cans, as well as slow-acting carbs, so things like muesli bars, dried fruit, and crackers. With our recovery, as we said, it's a balance between avoiding hypos and optimal blood sugar levels for encouraging recovery. Consistent high blood sugar levels can indicate infection, so it's important to seek medical attention if you notice any signs of infection, and we've got them listed over here. So it's extreme soreness after the initial pain has settled, redness, discoloration, and heat around or near the wound, discharge or oozing, and fever and gaping along the wound. Wound healing can happen more effectively with euglycemia or normal blood sugars and rest as much as you can. It's common to have mixed emotions after your baby's birth, especially with a high risk pregnancy. So you can request a birth debrief from your hospital or your birthing team, and they can help you to understand why certain things were done. You can request access to your birth notes from the hospital, and many psychologists and counselors are available to help you debrief, and they may be independent of the hospital. If we're needing more support, some of the services that we have available, so one of them is Raphael Services, and this is where you get to speak to a mental health professional. If you get a mental health care plan from your GP, there's no gap to access this service, and it's available for women who are pregnant until their child's fourth birthday. There is also the King Eddie's mental health service, and you can self-refer as a patient of King Eddie's. Last little bit is we've got all of the references. So a couple of pages of those. Thank you so much for listening to this presentation. If you've got any questions, please feel free to send them through, and we'll be happy to answer them as we can. Um, hope you've enjoyed this. And again, as we said, we're aiming to um, empower you, not scare you. So um, these are just setting the expectations which you can then discuss further with your healthcare team.